Perfect. Thank you so much for the feedback. And first of all, thank you very much for the kind invitation to present to this meeting. I'm very happy to be here. I'm very grateful for the possibility to speak about long COVID in this occasion. And thank you very much to the organizer and to all the people who are here to listening to my presentation, which is about canaries in the coal mine, patient activism in the early COVID epicenter. A few words about myself, just to introduce me. I'm Elisa Perego. I'm an honorary research fellow at University College London, but this is an honorary position, so I actually live in Italy, in the early COVID epicenter of Lombardy. You might remember it. I share this because obviously I'm a long COVID patient as well as a long COVID patient researcher and activist, as well as a researcher who works on other topic. But I wanted to make clear that I'm in Italy, so I'm talking about something that I live through myself. So basically, pandemics are history-making events. That is, these are events in human history that change the course of events, of how human history develops. The way in which we record the history of a pandemic has massive implications for public health, the safety of the public, the way in which we are going to prevent and to try to do better in the next pandemic that will come. It also has a massive implication for accountability and justice. We know many mistakes and errors have been made in the COVID-19 pandemic, and many people are paying the price for this. It matters for activism and for historical transparency and truth. It matters for patient and disability rights, as well as so many other things. It is important to think that a critical event or series of events and experiences in the COVID-19 pandemic is patient activism by the survivors of COVID-19 in the early epicenter of the pandemic. These are people, including myself, who came to deal with the new disease, obviously the novel coronavirus, COVID-19, often on their own, often with no medical care at home, in a collapsed healthcare, in the context of devastated healthcare system. These people alerted the world about the true nature of COVID-19 and brought long COVID to light. And all of this bring me back to the title of my presentation, Canaries in the Coal Mine. What is a canary? A canary is a bird which was used by coal miners to find out about dangers. These birds were taken to mines because they were very successful, very sensitive, for example, to the presence of dangerous gases in the mines, and therefore, sadly, often dying before humans were aware of the danger, gave information, gave testimony, let's say, gave evidence that there was a danger in the mine. And the phrase canary in a coal mine is now used often to refer to people who sense or have evidence or experience of some danger and fight, or in another way, make other people aware that there is a danger. And these are the COVID survivors from the early epicenter. SARS-CoV-2 has now recognized as a virus with high mortality and morbidity. Of course, mortality has gone down a bit in the pandemic, but still there are around 7 million official deaths recorded. But estimates based on excess mortality speak of 30 or even more million people dying from COVID-19 to date in the pandemic. It is also estimated by some research papers that around 20 million lives might have been saved by vaccination in the first year, the COVID vaccine, in the first year of deployment of such vaccination. Despite this, it is estimated that hundreds of million people, maybe even 400 million, have experienced long COVID. And in view of all of this and other factors, my opinion is that the COVID-19 pandemic is one of the greatest health disasters in recent human history, especially if we consider we are in the period of modern medicine and present-day technology. Past pandemics such as the so-called Black Death in the Middle Ages or the so-called Spanish flu pandemic at the beginning of the last centuries are estimated by some researchers to have killed more. But, as I said, we are in a period which preceded the introduction of modern medicine, of vaccination for the pathogen in question, of antibiotics, of intensive care, and so on. So what I mean is that now we have the technology to make, to prevent maybe this pandemic, or to make it less severe than it was. But this, unfortunately, in large part was not done. And coming back to the topic, to one of the main topic of my presentation, long COVID. Long COVID is part of the history of this pandemic. It's a story of collective, groundbreaking, international, grassroots activism by patients, by people who survived COVID-19, especially in the first wave. What do I mean by long COVID, especially broadly, the scope of the presentation in relation to what long COVID was defined by COVID survivor in 2020. Long COVID is a patient-made term, a phrase coined by patients for SARS-CoV-2 infection, long-term symptoms, clinical signs, and sequelae, such as newly triggered condition by SARS-CoV-2, which means a clinical case definition for conditions such as pulmonary embolism, diabetes, kidney disease, you know, all the sequelae we now hear about in the press and in scientific research. In the term long COVID focuses on prolonged multi-system disease arising from SARS-CoV-2 infection in the prolonged disease process, which starts when a person comes into contact with SARS-CoV-2, and then, you know, what happens next into their body, and the severe, sometimes severe consequences up to death, which can happen in the long term. So let's go back to pandemic history, to the early 2020. You might remember as it was, COVID-19 was presented in the press by policymakers, even in some clinical guidelines, as a short, mild disease, mainly a respiratory illness, which was supposed to be, in most people, especially in the young and healthy, not a big problem. Only those who were said to be old and sick, those with comorbidities, were said in such context to be at risk of severe outcomes, such as death from SARS-CoV-2 infection. And there was a recovery timeline. So people were supposed to recover from COVID-19 in 2 weeks with a mild case, and up to 6 weeks for a severe case. There was this dichotomy. Either you recover quite soon in a few weeks, or especially if you were already sick, you died. But we now know very well that this was wrong, incorrect, erroneous. During the course of 2020, acute COVID was increasingly being characterized and described as a multi-system disease with a strong cardiovascular and thromboembolic component. The survival of COVID-19 in the first wave in early 2020 contributed in a critical way to revising those early wrong, erroneous view of COVID-19, which I have described in my previous slide. Survivors of COVID-19 contributed critically, drew attention to the fact that COVID-19 was actually not short in many people. Actually, it was a prolonged, or it could be a prolonged severe disease, even in those who were deemed to be at low risk from SARS-CoV-2 infection, including potentially in children. And this is why one of the key reasons we have long COVID comes from activism, comes from advocacy, comes from the patient community. It was a way to say, no, let's be careful with these guidelines, with this communication by policymakers and authorities. COVID is not short. Long COVID has been called the first disease identified, named, and defined by patients finding one another in social media such as Twitter. And this is something that many don't know because it's not talked much about, especially in the press and in the medical community. Long COVID is a term and it is a concept which emerged within the patient community of COVID survivors. The first research on persistent symptoms from SARS-CoV-2 infection in long COVID was produced by patients themselves, by survivors. And the definition of long COVID by patients themselves has been said in various sources, which I have documented in some of my own publications, which I have cited and I will cite across the presentation. It's been said to be a key inflection point in medical history, a revolution, an advocacy research movement that changed the art of medical history because it completely changed the way we see COVID-19. The interesting thing is that the definition of long COVID by patient as a disease entity and also as an advocacy grassroots movement took place by a means that fall outside the channels of conventional medicine. So in normal medicine, conventional medicine, we have peer-reviewed publication in big journals, we have clinical guidelines, we have the authority of the medical professional. But no, a lot of the early information on COVID-19, especially non-hospitalized patients, came to light through a lot of other means, such as threads on Twitter, tweets, chats such as in WhatsApp, posts on Facebook, interviews in the media by patients, informal polls, surveys developed in patient-made support groups, blogs, short pieces in medical journals such as the BMJ, British Medical Journal. We will see some examples later. And even some of the first peer-reviewed publications on long COVID were written by patient researchers, that is survivors, who were not medical professionals or researchers in biomedicine before writing about COVID and long COVID. So it's something which is really a very peculiar phenomenon in medicine. No? We have patients taking the lead. A bit of the story, more in this story. March 2020. The first, at least in the West, obviously, we know a bit less of what was going on in China and so on. First-hand reports of a prolonged illness from SARS-CoV-2 infection, as well as a COVID, a form of COVID, who was not mild, even in those who were not in the hospital, started to come out on social media, such as Twitter. And patients affected by COVID-19 were using hashtags that I call them early hashtags, because now they are not used very much anymore, but they are still on this platform on Twitter, such as #MyCovidDiary or #MildCovid. MildCovid often used in an ironic sense to say, no, listen, okay, we are not in the hospital, we are not in ICU, but this is not a mild disease. I share a couple of examples. These are still on Twitter. They are in the public domain. They are still there. But I remove the name for privacy, but you can see people sharing their medical tests, people advocating for recognizing this form of mild COVID. Okay, let's say it's not really so mild. And these are both from March 2020. At the end of the same March, Dr. Rachel Pope, a lecturer in the United Kingdom, started on Twitter a very long thread spanning multiple weeks or even months, describing her experience of COVID-19. You can see a few tweets there, but I didn't share the whole thread because it's very, very long. And she was describing a multi-system COVID illness, a very long COVID illness. And although Dr. Pope was not hospitalized in the acute phase, she later developed very severe cardiovascular symptoms that brought her to the emergency multiple times. And this is something I recorded in one, with permission of Dr. Pope, in one of my publications, so it is shared publicly in my publication, so with permission. April 2020, these first-hand reports of prolonged symptoms from COVID-19 grow in their intensity and quantity on social and other media, such as, again, Twitter, but also other media. Survivors share about their symptoms, their clinical signs, such as prolonged fever, low hypoxia, tachycardia, and so on. They share hypotheses about what was going wrong with them. They share the results of any test or medical test they had at their disposal. And thanks to, obviously, social media, there was a lot of international interaction. People in different countries, in different epicenters, Madrid, London, New York, Italy, Bergamo, Lombardy, were coming into contact thanks to social media. And this is something which makes this pandemic peculiar, because it's maybe the very first pandemic in the age of social media. Among patients, there was also a lot of engagement on the medical, clinical, and scientific papers on acute COVID-19. So people were saying, okay, now we see that in acute COVID, there is a cardiovascular problem, there are cardiovascular problems, thrombotic problem. Is it possible we still have this problem in the long phase of the disease? It is a period in which yearly patient created names and tasks to quantify and to speak about prolonged symptoms were created, such as long haulers by activist and patient Amy Watson in the United States of America, but also more relevant to France, après-Jevan in mid-April. And this is the après-Jevan first tweet and some of the first artwork by the après-Jevan group shared with me kindly by après-Jevan, the après-Jevan support group in Charity. May 2020, there is a growing discussion on social and media by patients and now also by journalists. This problem is starting, people not recovering from COVID, starting to picking up into the media. There is a growing creation and establishment of support groups created by patient for patient, such as what the Facebook group in the UK, which is now long COVID support. On the 8th of May, Professor Felicity Callard in the UK, a very prominent long COVID researcher and advocate, published this piece on the academic blog Somatosphere, very mild COVID symptoms and illness classification. And this was a very important piece because Professor Callard basically blew up the concept of mild. She showed that even people who were not hospitalized, who were relatively young or young, could go through a life-threatening, potentially trauma, a life-threatening, very severe and extreme disease. COVID was not mild. On the 11th of May, the research group in the support group, the Body Politic in the United States, released a report based on a survey of people in the Body Politics support group, tracking symptoms, persistent symptoms for around 2 months, and showing a lot of symptoms pertaining to many body systems, so not just a respiratory disease, and a very low recovery rate, at least in their survey. And on the 20th of May, the ASH non-COVID term is created. And although it's a term created in Italy, but in English, but it is a term, obviously, that then went viral internationally. You can see, for example, there a German piece. I want to share to you a tweet of mine, one of the first tweets in which I use the long COVID name to refer to aspects of this prolonged COVID pathology. It's just at the end of May 2020, and I was commenting on an Italian article in which the Society of Pneumology of the Lung Disease in Italy was saying that among hospitalized patients in Italy at the time, it appeared that 30% of survivors were found to have long-term and potentially permanent lung problems. So the Society of Pulmonology in Italy was raising the alarm. They didn't speak of long COVID, but they raised the alarm about this sequelae. And I think they were also mentioning the first SARS, saying many people from the first SARS had long-term problems with the lung. We are concerned that this will be the case of COVID. And I want to mention this tweet because you can see that the COVID name was immediately applied to very severe and concerning issues, such as organ damage, maybe permanent organ damage. We now know from the science that there is long-term, maybe permanent organ damage in long COVID, as well as we know that SARS survivors, the survivors of the first SARS, still today are not fully recovered, at least those who have been subjected to medical analysis. Let's go to June, July 2020. The term on COVID goes viral. It started moving into the press, research, and even policy making. I think there was a discussion even in the UK Parliament in which the term was used. And there is an intensification of patient-led calls on prolonged symptoms in sick by using patient-made terms and hashtag. I share again one of my tweets, and I'm sharing my tweet not because I believe obviously my tweets are more important than the tweets of the hundreds and thousands of other people who were tweeting about these prolonged symptoms and disease, but for private placebism. And it is important because you see that I use many hashtags, many patient-made terms, including precedent, long COVID, COVID lungo, which is COVID long in Italian, and many others, but to speak about a young nurse from Italy who, after being killed for months, was developing thrombosis. So again, the term long COVID was since the beginning applied to emerging evidence of very severe, potentially fatal severe long-term health effects, even in young people. So we knew since the beginning of the pandemic what this virus was capable of. And obviously, in social media, you can interact with many other people. These threads I mentioned, Dr. Rachel Pop one, people were interacting, were discussing, sharing hypotheses. So there was this dense process of collective knowledge building, which created a grassroots movement, which forced policymakers, such as the World Health Organization, to recognize long COVID. And we are out now to August 2020, the 21st of August. At a private meeting with the patient researchers, advocates for long COVID and other people, the World Health Organization recognized long COVID. I had the opportunity to be present. So, I have first-hand evidence, first-hand experience of what was said at the meeting. And the World Health Organization soon recognized the long-term effect of SARS-CoV-2 on their social media, and later developed a clinical case definition under post-COVID condition, although they also use the patient-made term on COVID. And this vaccine period, we still have tweets, patient reports, patient interviews in the media, and also patient writing. For example, in the British Medical Journal, BMJ, you can see an example, a blog, a piece in which people present at the meeting, if I'm not mistaken, this is from every September, report that the World Health Organization is listening to patients and will act. September 2020, I share one publication of mine with some amazing colleagues such as Felice Callard, Tal. You can see the name there, Rachel Pope, and many others. Why the patient-made term non-COVID is needed. This was maybe the first publication in the world. It was a short piece, but the first publication in the world in which there was a discussion of sequelae, of what long COVID was, of the mechanism, including potentially viral persistent. I want to share you a brief passage of this publication. Mild manifestation in the prodromal stage. The prodromal stage is the first days of the first days of the COVID, can progress to severe disease and sequelae, including cardiovascular thrombotic and neurological manifestation. We knew in 2020, all of this is recognized widely and demonstrated widely in research today. And this is another tip of mine, in which, again, you can see how the hashtag were used, patient hashtag, such as long COVID, Prejevan, COVID persistent from Spain, etc. And a mention of information coming from Italy about myocarditis, which is an inflammation of the heart muscle, which is attested both in acute and in long COVID. And you see sequelae, cardiac sequelae. Patients were COVID survivors were aware of this damage back then. And this was starting to emerge in research at the time already. October 2020, I want to mention my publication with Professor Phyllis Callard, How and Why Patients Made Long COVID, which is the first, also in peer review journal, the first recording of the history of the patient-driven advocacy movement, and the first documentation of the patient-made origin of long COVID. And I think this is a publication which was quite influential, because by documenting the activism by COVID survivors, this gave solidity to the advocacy research movement as a social, scientific, and activist phenomenon. And you can see how strong was already the advocacy, the degree of recognition also of the role of the patient, because the top scientific journal, Nature, made an editorial on long COVID just a few days after our publication at the beginning of October. Long COVID, let patients help define long-lasting COVID symptoms. So please let patients speak up in defining what's going on with them. December 2020, January 2021, the patient-led group from the United States, now patient-led collaborative, published a print documenting symptoms based on a survey at 7 months. Many people, not recovered 7 months. Now it seems obvious, but obviously at the time it was very important to demonstrate with the publication that people were not recovering from COVID-19. Patients were starting and continuing to share information about very severe disease, not just maybe a bit of fatigue, a bit of headache, a bit of migraine. As sometimes long COVID is presented in the press, you have a cardiac problem, hypoxia, low oxygen level, anomalous thrombotic markers. Patients were sharing about this in chats on Twitter and so on. And we are almost 1 year after the first wave. Patients were reporting ahead of a peer review publication by conventional, that is non-patient researcher, and medical professional, because of course peer review publication takes time, but this information was being shared in real time. And I want to mention also a meeting that I had with Marta Sperti, an activist and patient researcher in Italy, and the people from the Italian government, the Italian medical community, in journalism at the end of January 2020. the Long COVID Italia Open Day, because this was one of the very first push which led to recognition of long COVID, name long COVID with the patient term, not with terms created by the World Health Organization or the CDC or whatever, in a country which was Italy. Italy recognized long COVID with guidelines as long COVID with the patient name. And I want to conclude this short series of snapshots of a patient-led advocacy with some information which surfaced in February 2021. The case of Marta Sterchi from the patient-led advocacy and research group Long COVID Italia, Long COVID in Italy, PhD candidate. After a lot of work on her part, was very, very involved in Marta's stories. Marta Sterchi had the possibility to receive this PET CT scan, which look at her lung and vascular circulation and the state into her lung. You can see here, one of the lung especially is almost dark. It means the blood is not flowing in. It means there is damage potentially to the vascular bed of the lung, especially in the not in the center of the lung, but in the peripheral areas, like in acute COVID, because this is also very common in acute COVID. And there might be microthrombi, microclots into the lung. And this was at 1 year timeline. So after 1 year from the infection, people were still like this. Now there are many publications on the use of these techniques, also in children, proving this phenomenon is well established and is now well documented in the medical literature. But at the time, it was a shock. It was really a bomb. And Marta's Twitter, she shared this on Twitter very openly, went viral at the beginning of April, and received hundreds of thousands of visualization, and it had, I know, it had a huge impact on the scientific community. This is shared with the permission of Marta Sterchi. Thank you to Marta. And now, to wrap up my presentation, to conclude, I would like, to share something a bit personal, something about how I felt in doing this, in having long COVID, in surviving severe COVID in an early COVID epicenter with no medical care. I'm still ill today. I can't work. I'm still ill today. And I did a few months ago this brief interview for an empowerment patient website. And I said this to the person interviewing me, basically about the advocacy movement. This is just my personal experience. It might not apply to others. It, that is doing advocacy in COVID, felt emotional, empowering, and innovative. I saw it a bit through the eyes of a researcher. You see, obviously, I was a professional researcher, so my experience might be a bit better, be different than other people, but it is what I want to share with you. Being so ill, but also so free to build something new at the extreme frontiers of knowledge in a completely open access, immersive framework on Twitter with the new information coming out in real time, with a lot of solidarity among sufferers, the urge to understand, to alert the world, to try to spare others from what was happening to us. And this is to say that the story of long COVID, of the activism, of what we did, of what, 1,000 people built collectively, of what thousands of patients are still fighting for, it is really part of the pandemic history. It is something which deserves to be known, spoken about, recorded, written about. And this is something that I wanted to share with you. I hope my presentation was of interest, and I want to thank you, everyone, for listening to me. Thank you. And this is the end. I'm coming back.
There's a question.
Okay, hi, thank you for your presentation. I'd like to know if you would define the moment we're in right now as far as COVID activism is concerned. What's the most important evolution for you in 2024?
It's a difficult question because, yeah, I think there are some developments, such as, for example, the creation of a new case definition for long COVID in the United States of America, the NASM definition. I do not agree with everything, but there seems to be, more interest from some actors, maybe to act around this definition and maybe stopping saying long COVID is mysterious. And I think we are still, trials for treatment are still lagging behind. Many people are not able to access care. I'm speaking obviously of long COVID in terms of activism, because this is my talk. Prevention is also key, but obviously, thank you very much for asking. We know many people don't do that anymore. I'm a masker, but many people don't. And so many people are still being infected. We see, especially in Europe, there is not so much funding specifically for long COVID. There is, there is the need to really acknowledge the disease, the vast spectrum of the disease. Obviously, it might be a bit different in different countries, but for me, prevention of a new infection, containment of the pandemic, and recognition of long COVID are still critical. Although it's not an easy moment, obviously, because we are being said it's a cold. We are being said that long COVID is not so serious, or it doesn't matter for those. It's not a problem for those who don't have it. Just a minority of people. It is a difficult moment. Access to vaccination. It's not an easy period, in my opinion. I don't know if you agree.
There is a question in the chat. I have a difficult question about how you deal practically or morally with denialists and people that pretend you invented your symptoms. Is there a way to keep your spirits up?
It is difficult because there are many different levels. No? I pick maybe not just personally, but in general, because some people have people in their own family not believing them. In general, in my personal life, I'm also the peculiar situation, I have to say, because I was already chronically ill before COVID-19. No? So in some cases, for example, let's say I have, I don't know, to speak to someone, I don't want to disclose, to speak about long COVID, but still say I'm disabled. I can mention other diseases. You know, there are always difficult choices in this. I mean, in a very peculiar situation. You know? And then, obviously, there are situations. There are. I don't know. I have one of my. One of the most difficult things for me is actually not personal, but because I'm a lot on social media, I'm involved a lot in activism, and for me it's, you know, people who say long COVID is invented, you know, this is not the hardest thing actually. I have more difficulties with people who try to recognize long COVID, but minimize the impact of the disease or the role that patients have, people with conflict of interest, medical professionals who want to take credit for discoveries that were made by patients. There is a lot of which is not public about this. It's difficult. It's a moral injury. What's going on for me with this pandemic? I don't have an answer because it's really, you know, it happened to me to cut a relationship. For example, a person who at a certain point insisted, they didn't know I had COVID and long COVID, but they knew I was chronically ill from before already the pandemic, and this person insisted, it was when the lockdown ended, you know, insisted we went into like cafe indoor to take a coffee. And this person knew that I might be vulnerable to COVID and long COVID, even if they didn't know about my personal experience with COVID. And so, for example, in this case, in the long term, I cut the relationship with this person because I couldn't, you know, it was, you know, a person who couldn't think, you know, what they could do to me. You know, it's really, this is a situation. It was not a person very close to me. So obviously there are different situations. For example, I speak in general, such people are your partners or your children or whatever. But yeah, this is a personal experience of what happened to me and in the relation with this with my colleague. And yeah, it's difficult. I think many of you might have had similar experiences of, you know, difficult moments. Yes, I can imagine. Was there any other question? Sorry if, you know, it's a bit difficult to speak about personally about my personal experience. I'm quite a reserved person, but it's not easy, and there is pain, and there is, yeah, there is it's difficult with medical professional. Sometimes it could be difficult. Yes, thank you. Which question is this?
Okay, so one more question from the chat. How can we
Yes,
explain the difference in attention and credibility given to long COVID patient-made knowledge compared to other diseases whose patients tried to do the same thing, such as chronic Lyme, fibromyalgia, etc.?
There are, I think, I don't know, some of diseases such as fibromyalgia, where I am, for example, in Italy, are actually quite recognized. So it might be, there might be differences in different countries. But yes, I think there are, the situation of long COVID was particular for many different reasons. The social media age. So all this sharing, all this coming out, the huge amount of research which was made on COVID and long COVID, a very strong unified movement at the beginning, which was really pushing forward. The fact that obviously COVID was such a severe, devastating disease, I was in a center, here, I'm not far from, I'm in between Milan and Bergamo, the epicenter, everything. I can't express what happened, but you see, it was pretty evident also in survivors, in the hospitals, that they were not recovering. It was a huge amount of patients because COVID is so severe, so evident, and there were so many people. Obviously, a pandemic is the moment in which there is a lot of attention, and obviously we know that many other diseases, such as the ME/CFS, there has been also a lot of pushback in the past by what I would call fringes in the medical community, but they were not fringe because, this psychologization of such condition, which is a real tragedy, and unfortunately in part is touching on COVID as well. So there were many factors, I think, which also another factor which has been mentioned is that at the beginning, many people who got long COVID were also medical professionals, healthcare professionals, scientists. So obviously, we had the possibility also to publish immediately on the disease, to engage with the researcher. There were many factors, but I really hope that long COVID and this pandemic experience, something good comes from it, which is the recognition of other diseases triggered by infection, which have been poorly recognized so far. And I truly hope for this. Although obviously, it's difficult also for long COVID. Thank you.
Thank you very much, Elisa. We will stop here. We are happy to have heard you.
Yeah, thank you. Thank you.
Thank you
for taking.
Thank you.
Bye. Bye. Thank you very much. A pleasure.
Bye.
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 Thank you.